Okay, this lecture we're going to talk about commonly used medications in neuro patients. My name is Yana Bukovskaya. I'm the pharmacist in the neuro ICU here at Ochsner main campus. Objectives for this lecture are to review some of the common medications that you are going to see in your neuro patients, whether they're in the neuro ICU or the step-down unit. And we're going to discuss specific indications such as ischemic stroke, hemorrhagic stroke, and status. IV antihypertensive agents. Due to constraints, we can't talk about every single antihypertensive agent, so I'm just going to focus on the intravenous agents. When patients are admitted to either the step-down unit or the ICU, typically we may not always restart their home medications right away. So blood pressure control goals are going to be set by the primary team, and we'll use various IV antihypertensive agents to get to those goals. So one of the more common ones that you'll see is labetalol, which is an IV beta blocker, usually given as 10 milligrams IV push and can be repeated every 15 minutes as needed with a maximum of 20 milligrams per dose. A really quick onset of action and a moderately long duration of action, but since it's an IV agent, typically the effects are going to wear off within a few hours. With this agent, as with other beta blockers, bradycardia is a potential side effect, so that's something that the patient should be monitored for. And if you see a patient has a low heart rate before giving the medication, that might be to call the team to clear they want this agent to be administered. The antihypertensive agent has a different mechanism of action than labetalol. This is an arterial vasodilator. Also 10 milligrams IV pushed, which can be repeated every 4 hours as needed, maximum of 20 milligrams per dose. So very similar dosing on these two agents, but different mechanisms of action. Because of that, you're going to see less effects on heart rate, so it's likely to cause bradycardia. Now, this, unlike labetalol, is not permitted on the neuro step-down unit, so this should only be used PRN on a neuro ICU. Calcium channel blocker, and this is usually run as a continuous infusion, so whereas labetalol and hydralazine are given as IV pushes, cardine is run continuously. The dosing starts at 2.5 milligrams an hour. It can be titrated all the way up to 15 milligrams an hour. And because it's an IV agent, it does not last very long, which is why it's run as a continuous infusion. It's recommended to change the peripheral site every 12 hours to minimize venous irritation. Now, in general, for all of our neuro patients, their blood pressure goal is going to vary depending on the disease state, and the blood pressure goal is going to be set by the primary team. So when I get your patient, it's one of the things that you want to think about is what is the goal for this patient. If it's their blood pressure less than 40 or less than 180, less than 200, you're going to have several orders to help you maintain that blood pressure. So you may not have a nicardipine drip available, and if the patient is requiring multiple PRN pushes, you'll have a nicardipine drip as well as PRN pushes. If the patient is requiring too frequent pushes, you may need to switch to a nicardipine drip for better blood pressure control. So it's important to just establish what your goal is with the primary team. Make sure that all of your orders have the appropriate parameters set within them. And if you find using too many PRN doses, such as 3 PRN doses, and you're still having trouble controlling the blood pressure, this would be a reason to contact the primary team, and you may need to switch to a drip. On to pain control. A brief overview of pain control. We have several agents available to us in order to control pain. We have the non-opioids, such as the NSAIDs, or the non-steroidal anti-inflammatory drugs, which would include drugs ibuprofen, and also a non-opioid that you will frequently see is acetaminophen or Tylenol. And then we have various opioids varying in strength. So your weak opioids would include codeine and hydrocodone. Strong opioids would include morphine or Dilaudid, which is also known as hydromorphone. And there are several adjuvant agents that you may see different types of pain. So gabapentin and pregabalin would work better for neuropathic types of pain. So World Organization recommends utilizing the pain ladder when treating pain. So we're using a stepwise approach to ensure that we're using agents that appropriately match the intensity of the pain that the patient is experiencing. So if a patient has very mild pain, you don't want to jump straight to a potent opioid. So you would start at mild pain, maybe adequately controlled with non-opioid agents such as acetaminophen or ibuprofen. Add a weak opioid, and if that is still not adequately controlling the patient's pain, we may go to a stronger opioid such as your morphine or oxycodone or hydromorphone. So our brand name is Tylenol, is one of the most frequently utilized medications that you will see to treat patients' pain. It does come in several formulations, the PO route, the rectal route, as well as the IV route. The dose starts at 325 milligrams, or usually you'll give 650 milligrams per dose. Can be redosed at 4 to 6 hours, keeping in mind that the maximum total daily dose is going to be 3 grams. So you want to make sure that if you have a patient on acetaminophen and you're giving them frequent acetaminophen, giving it frequently, make sure that you're keeping track of the total daily dose. The dose may change if the patient has liver dysfunction, in which case we want to limit it to even lower, 2 grams per day. Acetaminophen used for mild to moderate pain, or it can be used as an adjunct agent to decrease the patient's opioid requirements. Monitoring the effect profile it's very well tolerated, so it has few adverse effects. And advantages is that it does not inhibit platelet function like your non-steroidal anti-inflammatory agents. So this agent is going to frequently be our agent of choice, especially in patients with neurologic issues. We're worried about bleeding. Bind to opiate receptors in the CNS, and they have affinity at all 3 receptor subtypes, the mu, the kappa, and delta opioid receptors. And efficacy depends on the receptor affinity and the subtype variability, meaning one opioid may have may bind to certain receptors, making it a more potent opioid. And an agent is really based on patient-specific factors. So we might think about the patient's history, when they've been on opioids before as an outpatient and have developed some sort of a tolerance, or whether they're completely opioid naive. We'll think about the adverse effect profile of the medication, the pharmacokinetics, the routes. That medication comes in a specific route that we are looking for in a certain patient, and the type of analgesic intensity and the duration that's required. So very patient-specific approach to selecting opioids for pain management. So it's morphine. Morphine is really known as the prototype opiate. It's commonly used as a comparison agent. It's the gold standard. It's a naturally occurring opioid. Can be given IV, IM, or PO. And it does have some active metabolites. So something to remember is that the metabolites are renally cleared. So if you have a patient with renal impairment or elderly patients, typically, they may have, the morphine may stick around a little bit longer. The effect of the morphine might stick around a little bit longer. So it may not be the best agent for patients with renal impairment. It does have it does amount of histamine release, so patients may complain of itching. Dilaudid is a semi-synthetic opioid, and unlike morphine, it does not have any active metabolites, so it has a lot less histamine release. It can be given IV or as well as IM, which we typically don't do, and it's a lot more potent than morphine. So every 1.5 milligrams of hydromorphone is approximately equivalent to 10 milligrams of morphine. Doses might seem smaller and actually quite potent. Fentanyl is given as a continuous infusion, but can be given as IV push as well, or bolus dosing, acting, and also does not have any active metabolites like morphine. Has some histamine release, but not as much. What we like about fentanyl is that it tends to cause the least amount of hemodynamic instability. So you'll frequently see this used in our ICU patients, and it's much more potent compared to morphine. So every 10 milligrams of morphine, as we said, was equivalent to about 1.5 milligrams of hydromorphone. That is also equivalent to about 1 micrograms of fentanyl, or 0.1 milligrams. So much more potent. However, frequently used PO opioids are hydrocodone mixed with acetaminophen. So if you do have a patient on this agent, it's very important to be aware of their total daily dose of acetaminophen and make sure that you're factoring that into your calculation and keeping it on the total daily dose. Oxycodone, which does come both formulation with and without acetaminophen. So typically we'll just use the single agent oxycodone when using this in our patients. Across the board, most opioids have similar adverse effects, and as I mentioned before, to varying degrees. So nausea and vomiting can be quite can occur, especially if your patients are opioid naive. This occurs most frequently with the first dose and should subside over time. And there are agents that we can give to help alleviate that adverse effect. Respiratory depression is an effect that we do worry about, especially if the patient is not intubated. So we want to monitor how much opioid we're giving to the patient and make sure that we're monitoring their respiratory rate. Make sure their respiratory rate is sufficient. Obviously, in your intubated patients, this is less of a worry, and sometimes we'll even use the opioids themselves, such as fentanyl, to suppress the respiratory drive if the patient is on a ventilator. And is one adverse effect that does not get better over time. This is something that's always going to happen as long as a patient is on an opioid. It's very important to advocate for your patient, and if you notice that they do not have a bowel regimen, that get one if they're on getting opioids. So I'm just reiterating some of the points that I already mentioned, making sure that we're having appropriate dosing regimens, not giving the patient too much, remembering that really true opioid allergies are rare, and morphine, as I mentioned before, is associated with the largest amount of histamine release. So if a patient is complaining of too much itching, it might be appropriate to switch to a different agent with a different structural subclass. And again, respiratory depression, we do have a reversal agent called naloxone. So if a patient is, say, on the step-down unit and gets too many opiates, they may require the administration of naloxone. Reverse effect to potentially prevent intubation. Nausea and vomiting, what we have agents to help alleviate that effect, and constipation, we always want to make sure that these patients have a bowel regimen. On to sedation. These 4 sedation for sedative agents, which are run as a continuous infusion, for the most part, they're all run as a continuous infusion, are mechanical ventilation. If the patient is undergoing invasive procedures, this would probably be more of a push dose. Reduce the oxygen demand, and in some cases increase patient safety and comfort. If a patient is intubated, this makes them more comfortable. Titrate the sedation to a specific goal. So you make sure that if you have a drip running, you are aware of what that goal is. Typically, we use the Richmond Agitation and Sedation Scale. So in that order, within order, there should be a titrate to a goal RASS of whether it's 0 or -1 or a deeper sedation. Common agents that you'll see used is propofol. This is a very short-acting lipophilic general anesthetic, and while we do not know exactly what the mechanism of action is, we do know that it acts on GABA receptors and may have some NMDA receptor blocking properties. Sedative effects, anxiolytic, amnestic, and anticonvulsive effects, which will be handy when we talk about treatment for status epilepticus. But it is important to remember that propofol does not have any analgesic effects. So if pain is an issue, propofol is typically coupled with an agent that does have analgesic effects, such as fentanyl. So you may see a patient on both these drips at the same time. Propofol is highly lipid soluble, and you'll notice that it is a white color, and this is because it is suspended in a 10% lipid emulsion. So this does provide a source of calories to the patient. So you'll notice that if you're having a patient that goes on or off propofol, the dietitian should address those calories and usually factor that into their tube feed goals or their nutrition goals. Propofol has a very rapid onset of sedation and a short duration of action. However, you may see that if the patient has been on propofol for many days at a time, they may take a little bit longer to wake up than if they've just been on for a day and you're giving them a sedation holiday. If heart rate and blood pressure, it may cause some bradycardia, we talk about here. Hypertension and bradycardia are quite common with propofol, and it's sometimes rate dependent. So rates will produce more hypotension. So to monitor for this. Respiration, these patients should really be either getting intubated or already intubated, so we really wouldn't be using propofol in their cases. For triglyceridemia, if a patient's been on high doses for a long period, for several days, typically start monitoring triglycerides. And propofol has been known to cause an acute pancreatitis as well. Dexmedetomidine, or brand name is Precedex, is another agent that you'll commonly see in the ICU. It's a selective centrally acting alpha-2 agonist, and it is approved for mechanically ventilated patients in the ICU, as well as non-intubated patients in the perioperative setting. So something very interesting about dexmedetomidine is that it does not cause respiratory depression. So you may actually see patients who are not intubated on a Precedex drip. And this is a very unique type of sedation where the patient is calm but easily arousable. So it is sometimes even possible to perform a neuro exam on patients through a Precedex drip. Precedex because compared to benzodiazepine infusions, which have frequently been used in the past in ICUs for sedation, it's been shown to have shorter times to extubation as a decreased prevalence of delirium. Again, dexmedetomidine has anxiolytic properties, analgesic properties, set properties, but respiratory depression, as I just talked about. Dexmedetomidine can be bolus when you're first starting infusion, but this is very optional, and most of the time we discourage the use of bolusing just because you tend to see a lot of bradycardia and hypotension with those bolus doses, especially. The typical dose is 0.2 to 0.7 mg per kg per hour, but we may go up to 1.4 as our typical maximum dosage. This brings to vasopressors. So these are all going to act on different receptors with varying degrees of affinity. So we'll go each one. Now, with all of these vasopressors, our goal is to get the blood pressure up if a patient is hemodynamically unstable. And so I'm going to want we're going to norepinephrine is your prototypical, the most frequently used vasopressor in the ICU. It is one agonist, partly, but with enough beta activity to avoid the reflex bradycardia that you'll get with a lot of alpha agonism. It does increase your MAP, your cardiac index, your SVR. It is used as the first-line pressor in septic shock. It's a potent vasopressor, and we dose it in mics per kg per minute. So start at 0.05 and may go all the way up to 3. You'll typically see it in your patients, so usually used for cardiogenic shock, and used for those patients that are having a lot of bradycardia. So the units are dosed in mics per kg per minute, 5 to 10 mics per kg per minute, up to a maximum of 20. Dopamine is that it has primarily beta-1 effects at lower doses, so 3 to 10 mics per kg per minute. But you get up to the 10 to 20, you're going to see more alpha effects, so more of the vasopressing effect. It has both positive inotropic and chronotropic properties, and will increase your MAP, your cardiac index, as well as your SVR as well. Epinephrine you can affect all receptors, so pretty evenly, so both alpha, beta 1, and beta 2, and used for all sorts of different types of shock, distributive, mixed shock pictures, or cardiogenic shock. Has both positive inotropic and chronotropic properties. So chronotropic properties would be increasing your heart rate or how fast it beats, and your inotropic properties would be increasing cardiac contractility. So trying to increase every contraction of the cardiac muscle, it increases its output. Also comes alpha than beta with increasing doses, also dosed in mics per kg per minute, starting at 0.02 and maxing out usually at 2 mics per kg per minute. You may see higher doses than this in very severe pictures, but we typically try to limit it to 2. The unique agent because it really only has alpha properties, so it is a pure vasopressor and doesn't cause as many tachyarrhythmias as all the other vasopressors do. But it is unfortunately less potent than some of the others. I typically see patients go on phenylephrine if they're having tachycardia or tachyarrhythmias from some of the other pressors. So we may switch to phenylephrine as a result of that. All dosed in mics per kg per minute, starting at 0.5, going up to a maximum dose of 5. Glutamine is mainly used in low cardiac output states, not as frequently used in the neuro-ICU, but you may see it from time to time, especially in those cardio patients. Typically used for cardiogenic shock or decompensated heart failure. And it does have positive inotropic and chronotropic properties with some alpha load reduction. So that is dosed in units of mics per kg per minute, starting at 2.5, going up to 20. Vasopressin is typically not a titratable drip, although we can titrate it, but usually we will just put it on at a steady rate of 0.03 or 0.04 units per minute. Unlike the other vasopressors, it does not act on the alpha and the beta receptors. It acts on the smooth muscle V1 receptors as an agonist. Typically used as either an add-on agent once the patient is already on pressors, on the doses of other pressors. When we're looking at our vasopressors, the effects across the board are typically going to be tachycardia and arrhythmias. Pressors are not considered something that we keep on a patient for long periods of time just because of these adverse effects. eventually lead to ischemia, meaning either gut ischemia or limb ischemia, and they can all potentially extravasate. So for this, we do have phentolamine, which is an alpha antagonist. It's typically injected subcutaneously into the surrounding tissue of where the agent extravasated. Our goal is to get patients off of vasopressors. Vasopressors are a bridge to stabilizing the patient during acute periods of shock, but ultimately we want to work on getting the vasopressors off. All vasopressor goals should contain either a blood pressure, whether it's systolic blood pressure or an MAP goal, as well as titration parameters. So they clearly spell out how frequently you can go up or down on the rate and by what amount. All of these have very short half-lives, which is why we run them as continuous infusions. And we want to make sure that when you're at the bedside, if you have a patient on a vasopressor, that there's no period of time where you've run out and you're waiting for a supply from pharmacy. So I'll keep an eye out on your supply. Make sure you're calling I'm calling ahead of time to make sure that you can get bags sent up if you're about to run out. Another thing to remember is that these can be concentrated. Some of them can be made into a more concentrated solution. So if you have a patient that is running at very high rates and requiring a lot of pressors, but also is flow restricted or they're getting too much volume from their pressors, it is possible to concentrate it. And status epilepticus. First element of seizure control is the quickest, basically the most acute response you can give to a patient who's having a seizure is a fast-acting agent with benzodiazepine in this case, but short-acting. So lorazepam or Ativan is going to be our preferred agent for the IV route. Typically given either in 0.1 mg per kg, or typically given is either 2 or 4 milligrams per dose. Be repeated within a few minutes. So you may give, the physician may ask you to give 2 milligrams or 4 milligrams, and then if the patient still has not stopped seizing, that dose may be repeated. About a maximum dose of 8 milligrams in non-intubated patients. If a provider is at the bedside, they may tell you to go above this maximum, but as long as they're at the bedside, that should be okay. The reason we have a maximum dose on benzodiazepines is because of their potential to cause respiratory depression. So particularly if we give too much of a benzodiazepine, there is that risk that the patient may need to be intubated. So what our total dose is of the benzo that we've given to the patient, especially in an emergent situation. Midazolam is also available IV, but it can be given IM. So if a patient has no IV access, midazolam is a great agent to use. This is 0.2 milligrams per kilogram, but we can give up to about 10 milligrams per dose. It does have less cardiac and respiratory adverse effects, but those are still there, the same as with lorazepam. If you enough of it, it could potentially cause respiratory depression as well. It does have a shorter half-life, so you may need to dose it a little bit more frequently in this situation. And the diazepam is an agent that's also available IV, so we can give it IV. It does come in a rectal formulation, so this can be given. This is typically used more in the outpatient setting for patients who are known to have seizures. This will be to their family members, so they can administer it. But in our scenario, if we do use diazepam, we can give it IV up to 10 milligrams. It's not to be administered IM, just due to its erratic absorption. But it's a highly lipophilic benzodiazepine, which means we all know that diazepam tends to last a longer period of time. However, because highly lipophilic, it quickly crosses the blood-brain barrier into the CNS. But just as quickly as it gets in, it also quickly gets out, rapidly redistributes into the body fat and muscle, which means that its anti-epileptic effects, anticonvulsant effects are actually quite brief. so it's actually quite short-acting in terms of controlling seizures. Overall, if you have a patient that is seizing, whether this is expected or unexpected, you should establish with the primary service what to do. So if it's a patient that's being monitored in the EMU, you should have a set protocol for what to do if the patient is seizing, or if it's a patient that's actively seizing, you should contact your primary service, and if need be, activate a core call. This typically is going to be lorazepam, but other benzos are available. Bottom line is that we do not want to delay treatment for these patients. And keep the dose that you gave if heating pushes several times. A benzo to our seizing patients. We're going to move on to other anti-epileptic agents, because once a patient is seized, we want to make sure that we have longer acting control. I mentioned before that the benzos don't last very long. They're great in emergent situations when we want urgent control, very quick onset, but because it lasts long, we want to make sure that the patient has some sort of coverage that's going to last over time. So one of the most commonly used agents is levetiracetam. We don't quite know its mechanism of action. However, we only use it for various reasons. It has very little drug interactions. It actually has no drug interactions, so we don't have to worry too much about other medications that the patient's taking. It is renally eliminated, so it requires some dose adjustment. However, you might see that we push doses in certain patients regardless. But you see that they'll get an additional supplemental dose after hemodialysis if the patient is in stage renal disease. Not a contraindication to using levetiracetam. The dose is typically going to be anywhere from 1,000 to 3,000 milligrams per day, but divided in 2 doses. In certain cases, such as if a patient is in status epilepticus or has very difficult to control seizures, you will frequently see loading doses. So that first dose of Keppra might be something like 3 grams or even higher. And the purpose of this is to get the anti-epileptic levels up in the patient immediately instead of waiting for steady state to occur after several doses. So levetiracetam is available in various formulations. It does come IV, but also comes in tablets and oral solution. And the nice thing about it is that it's a 1-to-1 conversion. So because it's 100% bioavailable, if the patient has enteral access, we would be easily able to switch them to either the tablet or the solution. Vimpat is another agent that we frequently use in our patient population. It acts on sodium channels. Typically is dosed between 200 to 400 milligrams a day, divided in Q12-hour dosing. And as with Keppra, you will likely see a loading dose on our patients, so it could be anywhere from 400 milligrams per loading dose all the way up to 10 milligrams per kilogram. So it's not uncommon to see the first dose be very high, followed by our maintenance dose of that's divided into Q12-hour dosing. Keppra, it undergoes renal elimination, may require dose adjustment as well as a supplemental dose after hemodialysis. And just like levetiracetam, it also comes in IV tablets and oral solutions, and is also 100% bioavailable, so we can comfortably switch from IV to PO. Now, we don't have time to go in depth into other anti-epileptics, and there are many of them, even more than listed out here, but there's some that you will potentially see in our patient population. Valproic acid is an older anti-epileptic that's still used today, also given with a loading dose, and then typically over Q8-hour dosing intervals. Older anti-epileptic, which we don't use as often anymore. Both of these will affect your liver function. Lamotrigine is typically an agent that's carried over from the home medications. It's not one that will frequently start in the acute setting. You may see them start this in the step-down unit, and this is usually a very slow titration up. So we would never load a dose of lamotrigine Lamotrigine. Is a newer antiepileptic, brand name Sabril. It does have a REMS requirement, which is basically for the patient's guardian or surrogate has to consent to the risk of vision loss, and the medication is sent directly to the patient on the patient's name. Typically, if it's a new start and the patient's in the hospital, it's just a pharmacy. If you are the bedside nurse and you get the patient's supply from the manufacturer, it should be walked down to the pharmacy. So typically these agents are kept in the pharmacy and then sent up as part of cart fill every day. And now if the patient is being transferred to another facility, and they are on vigabatrin, it's to remember that their supply is in the pharmacy and that should go with them. So it's not a medication that can just be ordered like any other medication and supplied by the facility that they're going to. So it's very important that they hang on to that patient's specific supply. Vigabatrin only comes in PO formulations due to the last agents on this list. So clobazam, topiramate, and perampanel are all agents that you may see added onto our patients' medication list, and they're all PO, and they're all antiepileptics. I very frequently see patients are more than one antiepileptic, and this is very common. Especially more refractory cases will require several agents to keep procedures controlled. As to refractory status epilepticus, we find as ongoing seizure activity despite the administration of appropriate doses of benzos and antiepileptic agents. So basically, once the patient has failed 2 different agents, and that can include the benzodiazepine, if they're still seizing that, and then we load them with levetiracetam, maybe even add lacosamide, and the patient is still having difficult to control seizures or still ongoing seizure activity, we would be an indication to start a continuous infusion that I have listed here. So we talked about propofol before being a sedative agent, but because it does have anticonvulsant activity, it may very well be used to treat status epilepticus. The difference between the order for sedation versus the order for status epilepticus is that propofol, in this case, for status, is going to be a non-titrating drip. There should never be sedation holidays or the drip for any reason unless the provider has indicated that. In this case, it is being used to manage seizures. Ketamine is an add-on agent that we may add to propofol, and we may run them simultaneously. And frequently, midazolam and lorazepam, which are the benzodiazepines that we talked about earlier, they can also be run as continuous infusions to control status epilepticus. And less commonly, more as the last-line agent, we might go to pentobarbital. So all of these are continuous infusions used to treat refractory status epilepticus. Ketamine is an agent that we haven't talked about as much before, so I'll briefly go over it here. It is an anesthetic agent and it does have some analgesic-like property, but here, for our purposes, here we're using it for refractory status epilepticus. It acts as an NMDA receptor antagonist, so it's a very different mechanism of action from the other agents. And dosing is typically 5 to 150 mics per kilogram per minute. So these are high doses, very different doses than if you've ever used ketamine for analgesia or other indications. So with propofol, you're actually going to see much higher doses of propofol if we're using it to treat status. And one thing about ketamine is that the Louisiana Nursing Board has deemed that RNs are not allowed to administer ketamine. So it means that must be spiked by the provider. So you call the provider over to the bedside, and even if you're taking a new bag and the patient's already in an infusion, you're just looking at the bags. It's something that at the time has to be done by the provider just because of this rule from the Louisiana Nursing Board. Okay, therapy is frequently used mostly in the neuro ICU. And this is really the backbone of medical therapy for the treatment of cerebral edema, which raise your intracranial pressure and can occur as a result of several etiologies. So it could come in with an intracranial hemorrhage, or they could come in with a massive ischemic stroke, or even traumatic brain injury. Anything that can potentially cause the brain to swell would raise intracranial pressure, be a reason for us to utilize hyperosmolar therapy to help control the brain swelling. Because the skull is a closed-in space, there's not much room for a damaged brain to swell. So surgical interventions, basically what we can do is offer the patients hyperosmolar therapy. So the principle behind osmotic therapy is really just increasing the osmotic gradient in the blood-brain barrier and the peripheral circulation, and causing the osmosis of free water from the brain parenchyma into the, which in turn decreases cerebral edema and hopefully lowers the ICP. That we have is mannitol, which comes as either a 20% solution or a 25% vial. Either of these can be used, can be administered via peripheral or central lines. And the dose 0.25 to 1 grams per kg. So you'll typically see pushes of either 25, 50, even up to 100 grams with deteriorating neurological exams. Even see around-the-clock mannitol, especially if the patient has persistent high ICPs, may be given every 1 to 6 hours. If it's over the clock, it'll typically be written for Q6 hours. The providers at the bedside, they may give it more frequently if assessing the patient and deeming that necessary. Adverse effects, we want to watch out for hypotension during the infusion. It's always pushed through a filter, so make sure you have the correct filter for that. And in remission, it can accumulate, so we want to make sure that we're careful when we're administering this to patients with renal dysfunction or end-stage renal disease. For too much mannitol is with the serum osmolality, so we really typically exhibit caution if the osmolality goes above 320 milliosms. However, this is not a contraindication. So we might see that if a patient has Q6-hour mannitol, we'll get a serum osmolality and a BMP about 30 minutes prior to the dose. Use the BP to calculate a predicted osmolality with the Lexicomp calculator. And you can measure osmolar gap, which is the measured osmolality minus your calculated osmolality, is greater than 20. The mannitol might be too high in the stream. Your osmolar gap represents solutes, such as mannitol, that increase the measured osmolality above the expected based on major electrolytes in the blood. So that's something that we'll monitor for, especially if we're giving mannitol around the clock. High saline, which comes as either 2% or 3%, will likely be infused of continuous infusions and usually done to target higher sodiums in our patients, especially in our patients in the neuro ICU. Both 3% are available as either the straight sodium chloride solution or as buffered solutions where 50% of the sodium ions are supplied by sodium chloride and the other 50% is supplied by sodium acetate. So this done to patient is running on regular 2 and 3%. They quickly become acidotic because of the high chloride load. a solution to that would be to switch to the buffered solution. It is also a little bit less harsh in terms of extravasation, so we may prefer the buffered solution if the patient has only peripheral access. So as mentioned, both of these run as continuous infusions, and that to a certain sodium goal, which would be set by the primary team. Now we know they are hypertonic solutions. Or if they're hypertonic solutions, we would always prefer a central line for them. However, it is preferred, not required. We are able to run both 2% and 3% peripherally. If 3%, we will try to limit the duration of infusion for up to 24 hours before we try to get a central line in, and we try to cap the rate at 50 cc's an hour. Usually, if a patient is still requiring to be on 3% after 24 hours, it may be time to reassess and decide whether that they might need a central line in order to continue the solution. Something to consider: if a patient has no central access and they have peripheral access, maybe we can get just running 2%, or maybe we can switch to the buffered solution. So there are all ways that we can continue giving the appropriate therapy to the patient while making sure that we're giving it in the safest way possible. If it's on hypertonic saline infusion, we would make sure that we're monitoring serial sodium, so at least Q6 hours apart, sometimes more frequently up to Q4 hours apart. Make sure we're monitoring the fluid balance, daily weights, daily ins and outs. And you may be asked to bolus a small bolus such as 250 cc's of either 2% or 3%, which you can do straight out of the bag. 3%, we have a more concentrated solution of hypertonic saline, which is 23.4%. This is an extremely high-risk medication, and we would always require that a central line be in place before administering it. So no exceptions for 23.4%. And unlike the other hypertonic solutions, this is not run as a continuous infusion. This is run at one dose, which is 30 cc's, which is equivalent to about 120 milliequivalents of sodium. It's given as a slow IV push and IV push. So the patient should be monitored, vital signs should be monitored, telemetry should be monitored while the push is going in. As of right now, we are asking that only neurocritical care providers are administering the 23.4%, to come to the bedside when the medication comes up from pharmacy. It is only supplied in pharmacy right now. They send it up, and then the provider should come to the bedside in order to administer it. And again, hypertonics, we should be monitoring serum sodium, telemetry going. I should mention one thing about subarachnoid hemorrhages. There is one medication that is specific to subarachnoid hemorrhages that you will come across, and that is called nimodipine. It has been shown in clinical trials to reduce the risk of morbidity from vasospasm in specific aneurysmal subarachnoid hemorrhages. It is a calcium channel blocker. However, it is typically we won't use it for any other indications except for these aneurysmal subarachnoid hemorrhage patients. So we wouldn't be using nimodipine to control blood pressure. It's minimal effect on blood pressure, in fact. However, the dose, which is 60 milligrams Q4 hours, may be split to 30 Q2, just if the patient is sensitive to it and does have some blood pressure changes with the administration of nimodipine. Typically, this medication is only given for 21 days total, and it is available as both a capsule and an oral solution. It's very important to notify the team the patient either doesn't have enteral access or loses enteral access for whatever reason, because there are no IV formulations, but it's just important for them to be aware that the medication is being held, if it is. To ischemic stroke, so many of our patients are going to be, whether they're in the neuro ICU or the step-down unit, many medications revolving around ischemic stroke. So the only pharmacologic therapy that we have for a patient with an acute stroke is TPA, or Alteplase. The way it works is it initiates local fibrinolysis by binding to fibrin in a thrombus, which converts entrapped plasminogen to plasmin. So fibrinolytic, plasminogen to plasmin, which essentially leads to the degradation of the clot. The dose for Alteplase is 0.9 milligrams per kilogram, but there's a maximum dose of 90 milligrams. So if a patient is kilos or more, it doesn't matter. Still, their dose is going to be 90 milligrams. The 10% of the dose is given over 1 minute as an IV push, and the remainder is hung over the next hour. TPA is a time-sensitive drug, as I mentioned. It's the only pharmacologic therapy that we have to offer to our ischemic stroke patients. And so we always want to be mindful of the fact that it has to be administered within the first preferably 3, but can also be administered within the first 4.5 hours of stroke onset. So delay the administration of TPA. And has received TPA, they will be monitored in the neuro ICU for the first 24 hours after the end of administration. So they will immediately be admitted to the neuro ICU, where they will have neuro assessments every 15 minutes for the first 2 hours, which then goes to every 30 minutes for the next 6 hours, and then Q1 hour for the remainder of the 24-hour period. The major side effect or complication to monitor for are any signs and symptoms of bleeding. And we're following our goal blood pressures, which are for TPA patients going to be around systolics of 180. Out of their acute stroke period, team is going to be focusing on secondary stroke prevention. Once a patient has already had a stroke, that means they have risk factors for having a stroke and they can potentially have another stroke. So what we try to assess is what the mechanism of the stroke was, what medications can we potentially offer our patients since they're one. What is a lot of these patients, if all of them, are going to end up on some sort of antiplatelet agent. Most commonly aspirin, which irreversibly inhibits the formation of prostaglandin derivatives, which is called thromboxane A2. Via platelet cyclooxygenase, which essentially leads to the inhibition of platelet aggregation. So when a patient is taking aspirin, their platelet aggregation is inhibited. And the second antiplatelet agent that we frequently see is clopidogrel, or Plavix. Plavix itself is actually a prodrug. It has to be converted in vivo to active form of the drug, which irreversibly blocks this P2Y12 component of the ADP receptors on the platelet surface. This essentially downstream also reduces platelet aggregation. Our antiplatelet agents, aspirin, which is usually either given at a dose of either 81 milligrams or 325 milligrams daily. The dose is typically decided by the primary team, where the patient's going to get 81 or 325. Clopidogrel is 75 milligrams daily. The patient may or may not get a load, which is typically 300 milligrams. And make sure that if you see strange orders, such as more than daily, that you address it with the team. Both of these agents, because we're decreasing platelet aggregation, the patient is going to be at risk of bleeding, so we're monitoring signs and symptoms of bleeding, monitoring their CBCs. And anything is usually a contraindication, so the patient should be stable before being initiated on an antiplatelet agent. Next, we have statins, which are known as HMG-CoA reductase inhibitors. So HMG-CoA reductase is basically the rate-limiting enzyme in cholesterol synthesis. So HMG-CoA reductase inhibitors or statins, they will inhibit this step, which in turn leads to less expression of LDL, the expression of LDL receptors, so you will essentially lower your LDL. Are going to end up on a high-intensity statin. You can see the doses here are either atorvastatin 40 or 80 milligrams, or rosuvastatin 20 to 40 milligrams. These are known as high-intensity statins because they have the highest lipid-lowering potential. Usually, if you have had a stroke, they end up on the high intensity. And the topic we'll talk about today is anticoagulation. So the most common and the oldest anticoagulant known is potentiate the action of antithrombin, which will aid thrombin and prevent the conversion of fibrinogen to fibrin, so prevent clots from forming. It is administered with weight-based dosing. It is a continuous infusion, so it's dosed in units per kilogram per hour, and we will typically use the adjusted body weight. So if a patient is obese or has a BMI greater than 30, we will typically use a lower body weight for the heparin protocol, for the heparin infusion, in order to avoid giving too much. It comes in a standard solution, the 25,000 units in a 250 cc bag. And this is typically run, so there are nurse-managed protocols that we use at Osh. A heparin order will come tied to a nomogram with your titration protocol. So you will check a 10A level every 6 hours, and based on that 10A level, we'll go down based on the protocol. What you will on some of the neuro patients, if you worked either on the floor or at other institutions, is typically omit the bolus doses. So we'll typically start the drip just at the infusion, and we won't start with the bolus, and we will typically omit the supplemental bolus doses if the patient has low 10A levels. This avoids bleed to minimize the risk of bleeding, especially in our patients who have had recent strokes and are likely to bleed. Anti-10A levels. What an anti-10A level? It basically directly measures the clotting factor 10A. And a newer technique, so if anyone's familiar with the older technique of using APTTs, we actually use 10A levels to titrate our heparin drips. So typical goal is 0.3 to 0.7, and this is the typical anticoagulation dose or range for the anti-10As for heparin. What you see is patients who have a higher risk of bleeding, we may want to narrow their goal, so we may make it 0.3 to 0.5. In this case, the heparin drip will be off protocol, and there's the nomogram that you use that is hyperlinked through the order set actually be modified by the provider team. So there should be a very clear titration instructions for you by the primary team if they want you to target a goal of anything beside 0.3 to 0.7. So make sure that you are very clear on how you're titrating your drip, what the goal is, and how you're going to titrate it. We measure these 10A levels every 6 hours. It's just because when you change the infusion rate on a heparin drip, that change is going to take about 4 to 6 hours to take effect and then be reflected in the 10A level. You want to be making the dosing changes every hour. You want to give a chance if you change the infusion rate. Enoxaparin, which is a low molecular weight heparin, it actually has a smaller chain length than the regular heparin, and it primarily works strictly on factor 10A. But enoxaparin, the thing to remember with enoxaparin is that it can be used as either DVT prophylaxis or treatment, and the dose that you're going to use is vary whether you're using it for DVT prophylaxis and treatment. The duration of action for enoxaparin is about 12 hours. So when you are using it for treatment doses, it's going to be dosed Q12 hours. And it does undergo renal elimination. So if a patient has significant renal dysfunction, we'll typically avoid enoxaparin. It can be dose adjusted if the renal dysfunction is mild, but typically we will avoid this agent if a patient is end-stage disease. As I mentioned, there are two different where you're going to be for DVT PE prophylaxis. In that case, the dose is going to be just 40 milligrams daily subcutaneously. And these doses that I'm going to talk about here that are weight-based are based on actual body weight. So that's going to come into play when we're using enoxaparin for treatment. So treatment doses, if a patient does develop a DVT or a PE, those doses are going to be 1 milligram per kilogram Q12 hours most commonly. Enoxaparin is not typically done because enoxaparin has much more predictable pharmacokinetics than heparin. We really don't need to resort to using anti-10A levels. It may be appropriate in some populations where those pharmacokinetics may not be as predictable. So if a patient has significant obesity, pregnant patients, or patients with impaired renal function, or if we're really worried about their bleeding risks, we actually monitor the anti-10A levels just to make sure that the patient is where we want them to be in terms of anticoagulation. 10A levels in these cases are going to be different than your heparin 10A levels. So for heparin, I mentioned it was 0.3 to 0.7. The 10 levels for enoxaparin are drawn as a peak. This is drawn 4 to 6 hours after you give the dose. It's better if the patient is at steady state, so usually after they've gotten at least 3 doses of enoxaparin, then we can draw a 4 to 6 hour 10A level after this is given, after the 3rd or 4th dose. And then 10A levels for the treatment dosing are going to be different, going to be a little bit higher, as you'll see, either 0.6 to 1 if it's BID dosing, or 1 to 2 if it's once daily dosing and treatment dosing. And then we can't keep these patients on IV heparin and we don't always send patients out on sub-Q enoxaparin, so patients will need to be converted to an oral agent if we're going to continue anticoagulation. Warfarin is the oldest agent and the most widely used. It's still very widely used despite the fact that we have newer agents, which I'll talk about shortly. Warfarin works by inhibiting vitamin K. Vitamin needed to make these vitamin K dependent factors. So factor 2, 7, 9, and 10 are the clotting factors in our blood that depend on vitamin K to be synthesized. So what Warfarin does is inhibit basically the production of vitamin K, leading to a reduction of these clotting factors, to be anticoagulated. So I think for warfarin is very complex in that we don't have a typical dose that we can give to all patients. It's very patient dependent. Warfarin has a lot of drug-to-drug interactions, and not only that, it has a lot of drug-food interactions. So, and then it's going to also depend on the patient's weight, any other concomitant diseases, and also genomics. So patients' own genetics are going to affect how they're going to respond to the warfarin. So it's really difficult to predict how much warfarin a patient's going to need. For this reason, it'll typically take around INRs daily. So our goal INR is going to be 2 to 3. And mechanism of action, because you're actually reducing vitamin K, and then you have to wait for the duration of the half-lives of those clotting factors. It would take at least 5 days for the warfarin to really take effect. In this meantime, you're monitoring INRs daily, and you may be adjusting the dose based on that. Even after the patient's therapeutic, in the patient setting, they have to follow up in Coumadin clinic make sure that their INRs are drawn and their doses are adjusted accordingly. So it's a very finicky drug for those of, initiating a patient on warfarin at the bedside. We want to make sure we're monitoring for signs and symptoms of bleeding. We're measuring daily INRs, but we also want to make sure we're monitoring clinically as well. Now, I mentioned that there's some oral anticoagulants, some newer agents available that may or may not replace warfarin. They are out on the market, and they are patients that can take them are convenient because we reduce the need to monitor these INRs, and because we have much more standardized dosing regimens. So the first agent to have come out was Tran or Pradaxa, which is it's a direct thrombin inhibitor, and it's approved for stroke prevention in AFib. Rivaroxaban was the next agent to come out. This is a direct factor 10A inhibitor, and it also is approved for stroke prevention in AFib. It's also approved for DVT prophylaxis and treatment. And the agent was apixaban, also direct factor 10A inhibitor, also approved for the same indications of rivaroxaban. So these patients, or the agents, the dabigatran, the direct thrombin inhibitor, basically going to inhibit factor 2, otherwise known as thrombin. Thrombin is very important for hemostasis, so it facilitates the conversion of fibrinogen to fibrin. It also activates platelets. So because dabigatran is direct thrombin inhibitor, it is inhibiting all of these actions. 10A inhibitors, like their name says, they inhibit factor 10A, prevents the conversion of prothrombin to thrombin, which will essentially lead to of platelet activation, conversion of fibrinogen to fibrin. The novel oral anticoagulants are more convenient for the patients because they do not require routine lab monitoring. They have much fewer drug interactions than with warfarin, and they have essentially no food drug interactions. The thing about the NOX is that, unlike warfarin, which, as I mentioned, takes at least 5 days to therapeutic, the patient is anticoagulated within 1 to 2 hours after taking their first dose of the novel oral anticoagulant. Even though they do have a lot of advantages, many of these agents are renally eliminated, so a lot of our renal impairment patients and stage renal patients are at a disadvantage, and they cannot benefit from these agents, so they would still have to depend on warfarin if they needed to be anticoagulated. These agents, dabigatran has some increased GI symptoms, that has some increased rates of GI bleeds. Some of the agents, dabigatran and apixaban, have twice daily dosing, which may be inconvenient for the patient, unlike with warfarin, which is only taken once a day. And then the big factor that we all talk about is reversibility. Whereas warfarin, if a patient comes in with a bleed on warfarin, there are several agents that we can give them to reverse the effects of warfarin. We can give them vitamin K, we can give them fresh frozen plasma, we can give them back the factors that the warfarin has inhibited with Kcentra. We have those options for the novel oral anticoagulants. So issue, dabigatran is the first agent to actually have a reversal agent recently released on the market. So potentially, but we have very limited experience with that. So hopefully with time, we will have reversal agents for these agents as well. But in the meantime, that still remains a big disadvantage of the novel agents. We conclude our presentation on commonly used medications in neuro patients.